Okay, so next is polytrauma and pelvic trauma V36. You are called to a trauma team activation in ED. A motorcyclist was hit by a car. On arrival, his pulse is 70, BP is 110/70. What are your management steps? So I will approach this patient by ATLS protocols: assessment of airway while care of the C-spine, breathing and ventilation, disability, exposure, and then on completion of the primary survey, I will do the primary adjuncts like pulse oximeter, ECG, urinary catheter, NG tube, and fast scan, X-ray, chest and pelvic X-ray. Then I will proceed with the secondary survey from head to toe examination, and I will do in necessary blood investigations and additional radiography, which I will pick on the secondary survey. On arrival, ED team shows you these X-rays. The patient is alert and talking. The ED team tell you that they have already completed the secondary survey. So they have shown X-ray of the right wrist, which is showing Colles fracture, and then the cervical spine anterior view and lateral cervical spine view, which looks normal. And any other investigation you would like to order? A trauma series for blunt trauma should include chest X-ray and pelvic X-ray. What is secondary survey for trauma patients? So head to toe clinical examination for signs of injury, including the back examination or log roll by 4 persons. And then ample history, allergies, medication, past medical history, last meal and events. And focused history and examination if possible. Your ED colleague has started a manipulation and reduction of Colles fracture with Bayer's block. The patient suddenly gets confused. His blood pressure is 95, but his BP is now 70 or 50. What do you do? So it looks like he is bleeding. So the source of bleeding could be from the chest, abdomen, pelvis, long bones, or any vascular injury revealed. So I would do the repeat primary survey and look for the cause of hypertension. Infuse IV crystallite 1 liter and call for emergency blood code red, and do investigation if not necessary. The chest X-ray and pelvic X-ray you asked for are finally done. The chest X-ray looks normal, but pelvic X-ray is showing a pelvic fracture, and it looks like vertical shear. What is the likely source of hypertension? What are your plans? So it looks like he is bleeding from the pelvis. So first of all, I will apply the pelvic binder or the battery to the coccus. And then after cessation, I would recheck the hemodynamics. If he has responded to cessation and I'm at center with the capability, I will request the intervention radiologist to radio embolize these pelvic veins which are bleeding. If there is no anti-embolization available, if he is unstable, I will proceed to pre-peritoneal packing and theater. How do pelvic binders and pre-peritoneal packing reduce the bleeding in the pelvic trauma? So pathophysiology, pelvic binder fixes the volume of the pelvis, and packing reduces the volume space, potential space for bleeding, and result is tamponade. True pelvic volume is about 1.5 liter, but disruption of this pelvic bony ring, the tamponade effect of the pelvic ring is lost. The vitreoperitoneal space can accumulate 5 liter of the blood, which is actually total blood volume for a normal human being. What are the potential sources of bleeding in the pelvic trauma? The source of bleeding from the pelvic venous plexus account 90% of the bleeding from pelvic fractures. Bony surfaces, arterial, pelvic organs, intrapelvic organs like bladder, urethra, vagina, nerves, sphincter, rectum, and soft tissue injuries. And suprapubic catheterization if suspecting urethral injury. Pelvic fracture with rectal injury is considered as the open pelvic fracture and patient needs fecal diversion. And then extra pelvic injuries, especially since pelvic trauma associated with a high velocity blunt injury. What pelvic fracture classification system do you know? So it's a Young Burgess classification. It depends on the mechanism. If anterior posterior compression, lateral compression, or vertical shear. So lateral compression and anterior posterior compression, one are mechanically stable, rest all are mechanically unstable. Another classification is also present, which is called tile classification. A more recent definition by in addition to the young burgess classification, unstable patient whose systolic less than 90, heart more than 120, evidence of skin vasoconstriction, altered level of consciousness with young burgess classification. So it's minor, moderate, and severe. So minor is patient is hemodynamically stable and fracture is mechanically stable. Moderate patient is hemodynamically stable but mechanically fracture is unstable, and severe both hemodynamically and pelvis fractures are unstable. His blood pressure and GCS are back to baseline after IV 500 crystalloid, and you bring the patient for CT. The trauma pan CT scan is almost complete when his blood pressure drops again to 90 or 50 and he is again confused. You bring him to the operating theatre for pre-peritoneal packing. On arrival in the operating theatre, the radiologist calls you and tells you of CT scan findings. So CTC spine, axial view, coronal view is showing the fracture 1, 2, 3, 4, 5, 6, C6 or C7 fracture with dislocation. How does change your management? In a patient like this with multiple distracting injuries like Colles fracture, pelvic fracture, now clinical clearance of C-spine cannot be achieved, hence even without his imaging, the intubation should be performed under C-spine control. Definitive management of C-spine injury will wait till after hemorrhage control is achieved, and C-spine must be protected until then. Would you consider this a polytrauma patient? What is polytrauma? Yes, so this patient has at least 2 life-threatening injuries, cervical spine fracture and pelvic fracture with hemorrhage in 2 different anatomical systems. A recent consensus definition polytrauma by the Berlin definition redefined are that it should be at least 2 body regions, AIS 3 or more than 3, and IASS more than 16 plus 1 out of the physiological parameters. These patients have increased mortality compared to the other injured patients. So this was polytrauma. Thank you.